Let me introduce myself again. I'm Plamen Todorov. I'm coming from Bulgaria, from Plovdiv, and I'm a rheumatologist. Okay, thank you. So my second talk, and thank you again for the invitation to the organizers and Professor Fodor. And my second talk will be the ultrasound in the diagnosis of knee osteoarthritis and why it's a valuable diagnostic tool that we should use. I have no conflict of interest whatsoever related to the topic. The outline of the talk will be general consideration for the use of ultrasound in knee osteoarthritis, ultrasound assessment of the major domains of knee osteoarthritis, not all because we don't have the time, but we'll focus on hyaline cartilage, synovial hypertrophy, effusion or synovitis, osteophytes, and menisci. And finally, we'll finish with the new updates according to the EFSUMP recommendations that were published last year. So, according to UR, imaging is not required to make the diagnosis in patient with typical presentation of osteoarthritis, but we can use them if we have a typical presentation, if unexpected rapid progression of the symptoms, and especially they focus on the fourth recommendation that to make additional diagnosis of soft tissues, the best imaging method are ultrasound on MRI, but as you would agree, ultrasound is much more cost effective and much more faster. Another review article tells us what is the place of the imaging in osteoarthritis patient management, and with the red dots, they think that the imaging could help us to detect inflammation, to see how many joints are affected, the rate of progression, and the stage of the disease, and maybe joint tissue metabolism and bone density, but these are not for ultrasound, but for sure ultrasound is for presence of erosions or calcification. So there are many places that we can use imaging biomarkers in the management of our patients. Potential sources of pain in the knee, because this is what brings the patient to our offices, this is the pain. So what could be the causes in knee osteoarthritis? It could be synovitis, usually it's low grade, but still it is there. Ischemia of the subchondral bone or the so-called bone angina, stretching of the joint capsule and supporting ligaments, meniscelegia, bursitis, cysts, enthesopathy of the periarticular tendons and ligaments, nerve compression from the osteophytes or thickened capsule, muscle spasm. These four can definitely be assessed by ultrasound, and these three may be partially assessed because, as our colleague showed us, we cannot see deep in the menisci, and also the stretching of the capsule, if there is no tear, we cannot assess. So what are the ultrasound equipment and what are the limitations? We use usually middle to high-end machine, linear transducers, grayscale ultrasound for structural changes, power Doppler or color Doppler, depending on the machine for inflammatory lesions, superb microimaging for low-grade inflammation, and shear wave elastography to see the stiffness and menisci of the menisci and the cartilage, and this is a relatively new field. And the limitation will be poor visibility in the inner regions of the knee, small width of some of the acoustic windows around the knee, and limitation in the range of motion of the knee in patients with advanced osteoarthritis will reduce the available acoustic windows too. Basically, for the scanning, we should use a tree position for the anterior scan, a neutral in 30-degree flexion, which optimizes sensitivity for effusion and synovial proliferative detection, and maximal knee flexion in order to assess the cartilage and to detect crystal deposition in it. Of course, we have also this for the medial and lateral longitudinal scans for the menisci, collateral ligaments, the popliteus muscle, and pes anserina tendons, and also we have the posterior for the possible Baker cyst, also posterior horns of the menisci, the nerves, but we all know this. So to start with ultrasound assessment of the osteoarthritic knee, the first thing is the cartilage. The echo structure should be homogeneous, anechoic. The chondrosynovial interface here above the cartilage should be sharp. the thickness of the cartilage should be uniform, and the chondrosynovial interface should also be sharp. So this will be the normal scenario, the normal image. Could we assess the cartilage with ultrasound? There was this study in healthy adults. They get several visits, and there was good reliability, good agreement between the different visits. So the authors conclude that it's feasible and reliable to use ultrasound for the thickness of the hyaline cartilage. There has also a study that compare the MRI and also the ultrasound to detect the thickness of the hyaline cartilage over the medial femoral condyle, and overall good correlation, but ultrasound tends to give a little bit lower values, so may overestimate cartilage thinning comparing to the MRI. So this we should bear in mind. This is according to Orsi, the course of changement of the hyaline cartilage in the course of osteoarthritis. And we see that the first imaging method according to this, the morphological MRI, where we can catch the early osteoarthritis, because with the conventional radiography we catch the late one. They didn't place ultrasound here, but maybe, to my mind, it should be here, because we try to push to early diagnosis, because then we have more treatment options than late. What are the sonographic features of degeneration of the hyaline cartilage of new osteoarthritis? We are changing the anechogenicity to hypoechogenicity, loss of sharpness of the chondrosynovial interface, and thickness could be variable along the cartilage strips. So it to be thinner here, thicker here, and not uniform like we saw before. And qualitative changes could be more reliable than the quantitative ones, because it could be challenging to measure the exact thickness in not so sharp borders, like in degenerated cartilage. There's one old staging, published 2000, but still it's, I think, very good. We have normal, then we have loss of the sharpness of chondrosynovial interface, partial loss of the cartilage thickness, full loss of the cartilage thickness but with normal subchondral bone, and full loss of cartilage thickness with defects in the subchondral bone. There's another more detailed scoring, up to 6, coming more recently in 2008, that also see of the Buert margin and loss of the homogeneity of the cartilage. Then we have Buert margin and complete loss of homogeneity, hard to define cartilage margin and loss of anechogenicity. Cartilage thinning is grade 5, so it will be very advanced, and complete loss of cartilage layer grade 6. So there are different grading in the literature, so you have to pick one and that is most feasible to use in your practice. These are some examples of asymmetrical thinning of the cartilage layer, like here. This is thinner here, here is thicker. Loss of well-defined cartilage margin and loss of the cartilage layer, and also here there was one with big defects on the subchondral bones. Another example, we have a diffuse thinning of the cartilage layer. You see here how thin is the cartilage layer, but with preserved subchondral bone. And we have a focal thinning only here of this lady patient. It was a lady patient with poor chondrosynovial interface also at the other places. So you see how detailed ultrasound could be. And another thing is these are two old ladies who look pretty the same on the photograph with valgus, and actually the left-sided looks worse. But when you do the ultrasound, you see that here you have preserved thickness with 2.3 millimeters and preserved subchondral bone, while here you have marked asymmetrical thickness and problems with the subchondral bone. So you see that the ultrasound can give you many details when you assess the patients. For the synovial hypertrophy and diffusion, synovium is abnormally thickened, hypoechoic, non-displaceable, and poorly compressible, sometimes with this nodular appearance. Sometimes when it's inflamed, you can see the power Doppler or Cower Doppler signals inside. As here is the synovial hypertrophy, and you see these signals inside. There's data that show that the synovial hypertrophy, positive power Doppler signal, and presence of joint hydrops are positively related with the severity and the worsening of the knee pain. So it's a thing that we should assess. And the effusion, anechoic or hypoechoic, could contain internal echoes that could be displaced. Joint effusion defect by musculoskeletal ultrasound is a predictor of the need of total knee arthroplasty, so we have to bear in mind this, how we check the effusion with this so-called sonopalpation. We press with the transducer, and then we see that the effusion is gone, so we are sure that this is a fluid. What about osteophytes? Big white bony outgrowths, very importantly for differential diagnosis, covered by anechoic hyaline cartilage like a black hat on them, found close to the joints. So here we have this outgrowth with hyaline cartilage covering. In omeract osteophyte scale is absent, mild, moderate, or large. We should measure them from the bony contour. What about the menisci? Appear as a continuous uniform hypoechoic triangular structures which are located between the femur and the tibia. We should assess the echo structure for lesion deposit and for extrusion. This will be quite normal one. And then we have the effusion menisci extrusion is secondary to joint space narrowing of the medial or lateral knee compartment, maybe one of the first ultrasound findings in knee osteoarthritis. So see here in the scheme how menisci is extruded and lifting the medial collateral ligament from the bone. The same we see on the ultrasound. We are seeing extrusion of the menisci, lifting of the medial collateral ligaments, which will produce instability in the joint. We can measure it from the bone contours to the end of the menisci. There are different proposals for cutoff points for importance of this protrusion. Some authors say 4 millimeters, other 5 millimeters. This maybe has to wait to reach agreement, but anyway, it's easy to do it. Also, you can do it in a patient that is standing and in a patient that is lying and see if the meniscus is movable, so unstable. And this protrusion increase with standing. So again, one good application for ultrasound and very easy to do in the practice. So we're gonna finish. No, we have one more for very large study with 270 patients with knee osteoarthritis. The relationship between the medial the extrusion of the medial meniscus and the radiographic progression was studied, and they found this, what I told you, that this value was important for the radiographic progression. Value of extrusion of the medial meniscus was found to be 5.5 millimeters. Again, it was measured from the bony contour up. So you have to bear in mind this value because the study was really large. Finally, some clinical updates on the use of ultrasound in knee osteoarthritis from the FSUMP guidelines and recommendation published last year. Especially for the knee, there were good and important updates. So ultrasound and MRI were found to be comparable assessing the cartilage defects. As we were speaking before, semi-quantitative grading and thickness measurements of the arthritic cartilage were sufficiently correlated with the MRI and with the histology. And normal reference values are easy and readily can be established in different populations. Again, some examples of the thin cartilage, thin cartilage with a regular bone profile and with one with defects on the subchondral bone. The second clinical update was about the osteophytes. So we'll go again over these 4 domains of the knee osteoarthritis. So ultrasound gives superior sensitivity compared to conventional radiographs for the detection of osteophytes. Grading scales for medial femoral osteophytes have also been developed with good agreement to the Cowgren-Warren's radiograph grading. again, the osteophytes, like bony outgrowths covered with huts of hyaline cartilage. And the third update was about the effusion. The presence of ultrasound detected effusion greater than 4 millimeters from the fat part above the femorus. Has also been reported to predict subsequent joint replacement. In addition, prompt detection of fluid is contributory for the onward intervention in the knees, especially the need for injection for aspiration of this fluid. And the fourth was about the menisci protrusion or extrusion. The initial ultrasound finding of menisci protrusion was found to be predictive of radiographic osteoarthritis. Of note, both quantitative and semi-quantitative assessment of medial menisci protrusion seem reliable when compared to the MRI. And you see that it's easy to see this extrusion. Menisci lesion, as we saw also from the previous presentation, we can detect it easily. Here is the normal one, here is with the lesion, some more lesions like hypoechoic clefts inside the menisci. So ultrasound of meniscus, especially medial, has a high negative predictive value of 93% and an acceptable specificity for meniscal lesions. However, if damage to the meniscus with possible requirements of operative procedures is suspected, MRI is necessary. So if we don't see anything, it may be deep, and if we plan operation, we need MRI. So with this brief update on the use of ultrasound in the main domain of the knee osteoarthritis, i.e. the cartilage thickness and quality, the osteophyte development of size, the menisci status with extrusion, protrusion, and synovial hypertrophy, which is usually a flow grade. I want to thank you again for listening and hope you enjoy this course and learn something.
Thank you, Plamen, for this update. If there are questions,